Hello, colleagues. I'm really glad to be here today with all of you. And thank you so much for making the time to spend some time with us on community-led monitoring. So it's really great to see that several of you in the call already has a good idea and understanding of at least the principles of community-led monitoring. I appreciate accountability, leadership, independence, community-led, and results. So we are already off to a very good start. For those of you who don't know me, my name is Keith Muniz. I'm a technical advisor here at the Global Fund in Geneva and the lead in the Organization for Community Systems and Responses, of which community-led monitoring is one intervention. So bear with me in the next few slides. I'm going to quickly take you through CLM, what it is, how does it work, what is your role in it, and sharing, like Corinne said, some stories of CLM implementation from around the world, particularly from DRC and our Nigeria colleagues. So CLM, in a very summarized version, can be structured along these four key components: understanding, feedback, adjusting, and improving. First of all, we need to understand, and communities themselves need to understand what the health and legal literacies are and how exactly they can collect data and develop indicators to continuously collect quantitative and qualitative data to assess whether those rights and health entitlements are in fact respected. CLM is also an opportunity to provide regular feedback where communities and clients of services have the opportunity to share their experience with accessing a service based on quality, affordability, acceptability, and accessibility, of course, from where the services are being provided, and that feedback loop goes from clients or communities to healthcare workers and to duty bearers. An important component of CLM is to co-create solutions to where problems might be impeding program progress. This includes working with and in partnership with health facilities and the people who work in these facilities to develop and identify solutions in how these programs can be adjusted, really focusing on results. And finally, to see and understand how these feedback loops, the indicators that's being tracked, and some of the engagement that has allowed the adjustments in terms of quality improvement and assurances have improved people's health outcomes. If you look on the far left on your screen, you can imagine a health system being a car that needs to go from A to B. You arrive with a specific issue, you receive a service, and you're on your way. Now, if you see that the car here has a wheel that's fallen off the car, but unable to get to fully functional driving ability, you can see CLM as potentially understanding a health system and identifying issues that might be wrong with it. In this case, the wheel has fallen off. And by creating a constant routine loop of information sharing, feedback, co-creations that are underpinned by accountability and independence so that this car can function and continue driving down the road. Next slide, please. So why is CLM so important for Global Fund grants? You might have seen in the Global Fund strategy that community-led monitoring is prioritized in support of people-centered services and meaningful engagement, as well as, of course, community and civil society empowerment. There are several reasons for the value add, or several points to note around the value add of community-led monitoring. First of all, it does provide you with a client perspective on what is working and what is not working in terms of a service that's being provided. It also then has the ability to boost the quality of said service by constant feedback loops that are constructive and that are engaging both civil society as well as the facility and the healthcare workers. It also is an opportunity to embed human rights in both local, regional, and national responses, because we can't speak about service quality without talking about human rights and gender equity. It also gives a good idea and provides some insights on who might be left behind and who are not accessing services and the reasons that they are not accessing services in order to improve. It complements quantitative data from routine monitoring and evaluation and provides some really, really critical insights from a qualitative perspective on how people are experiencing services. And it is an opportunity to strengthen a relationship between the clients or the service users and the service providers by bringing solutions to the table. Next slide, please. So there are several of you on the call today. We have CCMs, PRs, SRs, and other interested partners here today. And I think it's worthwhile to sort of point out what are our different and respective roles in supporting community-led monitoring. The saying is true that it does take a village. So at the end of the day, each of us has a very, very important role to play to support community-led monitoring implementation across the full cycle, or like we used to say, with fidelity. From the Ministry of Health perspective, or whichever state entity supports and delivers health-related programming, it's very important for government to support CLM from the get-go. This includes, of course, adhering and supporting the principles that community-led monitoring is led and owned by the community and civil society at large. And of course, facilitating access to key partners and health service delivery sites, to interview staff, to have or to review registers or some key information at the level of the facility. At the same time, there are several other areas that I'd like to also point out that the state and the Ministry of Health plays an incredible role in, and that is to ensure that there is meaningful engagement of clients and service users when it comes to discussing quality improvements around some of the programs and the responses. CLM between communities and governments really is a win-win. And you will hear later from DRC and Nigeria some examples of how this has really helped and improved the quality and responsiveness of programming. So PRs through the grants and CCMs should prioritize ensuring that community-based and led organizations have the necessary capacity to implement CLM, that CLM remains a priority intervention in upcoming Global Fund funding requests, and that there are mechanisms to engage to support advocacy based on the CLM data that the clients and communities produce. Here are some tips. You should meet regularly as CCMs, PRs, and this can be in your respective capacity or as the structure in and of itself to assess the quality and accessibility of services. Importantly, as more donors and technical partners are becoming interested in investing in community-led monitoring mechanisms, at the national and subnational levels, it's important to invest time and resources in coordination. There is, of course, as you can imagine, going down and furthering community-led monitoring as it evolves, some countries and mechanisms that are moving from manual data collection and analysis to mobile technologies and digital platforms. This is proving to be quite useful in terms of ease and effectiveness of producing reports from CLM data to support advocacy interventions. And last but not least, to ensure that when you describe and request funding for community-led monitoring implementation, to ensure that there are TA functionality and TA resources built into the program, especially if it's a move from manual to digital, if it would like to integrate other components of health and non-health issues into the community-led monitoring mechanism, and so forth. Next slide, please. I'll end off by saying you are not alone in this. There are several mechanisms for at least the remainder of this year where CCMs, PRs, SRs, country teams, etc., can access and request technical assistance for CLM implementation. But also this year in particular, there are some limited TA support available with the design and costing of CLM interventions for the next Global Fund funding request period. So you'll see in the middle, the stars are just to give you some ideas of the thematic areas in which TA can be requested. from indicator development and site selection to supporting bidirectional feedback loops, providing training on how to conduct advocacy using CLM data, and also to move from manual to digital data collection and analysis. I'll stop here and we will show you a video from ITPC, which I will talk to immediately afterwards.
En 2016, Médecins sans frontières a publié un rapport sur la situation de l'accès aux services antirétroviraux en Afrique de l'Ouest et du Centre. Ce rapport présentait une situation alarmante. Un grand nombre de personnes vivant avec le VIH n'avaient pas accès aux services requis pour le traitement. Nous avons mis en place, avec l'appui financier du Fonds mondial, le modèle d'observatoire communautaire sur le traitement, mis en œuvre par les communautés. Dans ce modèle, nous collectons des données le long de la cascade VIH pour s'assurer que les populations puissent avoir accès à ces différents services.
Renforcer les capacités de ces communautés-là, à prendre leur destin en main pour dire qu'on ne doit plus tendre la main, nous montrons que nous aussi, on représente une force qui peut aider à transformer la société.
La demande d'observatoire est très forte. Dans tous les pays où nous sommes passés, la société civile demandait comment vous pouvez nous aider à continuer les actions d'observatoire que nous avons démarrées.
They've been keeping us on our toes. Toes in the sense that they've been putting pressure on us in terms of whenever there are stockouts. They give us the alert to quickly distribute drugs.
L'Afrique de l'Ouest était une région pilote, mais le modèle peut être appliqué partout dans le monde. Donc pour cela, nous avons l'intention de susciter un plus grand intérêt des bailleurs de fonds pour plus d'investissements. Parce que cette initiative pilote de 3 ans a besoin d'être consolidée pour pouvoir produire des résultats sur le long terme.
Great, thank you so much. If you can go to the next slide. Thank you. So I hope you enjoyed a bit of an overview of the Regional Community Treatment Observatory, where ITPC Global was a principal recipient of Global Fund support in the GC5, or NFM2, if you will, across 11 countries over a 2-year period. And I'll quickly take you just through some of the results, but I'd like you to keep in mind the very first slide, CLM in a nutshell. Remember, we spoke about, or at least we highlighted, understand, feedback, adjust, and improve. So the same methodology applies, and you can see here how it applies in practice. So what happened once Alain has explained what the Regional Community Treatment Observatory did and highlighting some of the successes from that program's implementation. In 2017, in West Africa, only 40% of people living with HIV were accessing ARTs. So at that point in time, of course, you can imagine this being an epidemiological concern, and especially across the cascade when it comes to people on ART and being virally suppressed. Through some consultations, the challenges that were noted by healthcare workers and clients alike included drug stockouts, a weak health system that is not responsive or open or accessible, and several human rights related barriers that has also sort of impeded and contributed to low quality of care. So identification of the issue has been very clear in this particular region, and looking particularly at PLHIV on ART. ITPC intervened and introduced a regional treatment observatory. This was in February 2017. And this observatory engaged 11 national networks of people living with HIV and started to conduct treatment monitoring. So specifically speaking to people living with HIV on treatment around some of the experiences, at the same time as understanding within the facility how treatment is managed. This covered 103 health facilities. At the end of the day, and this is, you can see sort of the impact, which is the last little bullet around improving, you'll see that across several of these health facilities, viral load lab stockouts, remember there was a specific observatory to monitor drug stockouts and lab reagent stockouts, has reduced from 17 to 6% in 1 year's time. Of course, this is not as easy as the car driving with only 3 wheels to the end destination, but it took a concerted effort. And I think importantly, in that middle phase of feedback and adjust, this is where a lot of the efforts of this treatment observatory went to make sure that at the end of the day, there are some improvements along the cascade. Thankfully, to the lab stockouts that's been reduced, the rate of viral load suppression, and instead, or saying that people's viral load results returned, and this is much more known, in 12 months has reduced from 48% to 77%. Has increased from 48% to 77% in just 12 months. So I hope this has given you some idea and outline of community-led monitoring, you know, what it is, what your role potentially is in this. Here's an example of a regional treatment observatory in West Africa. And I'll soon hand over to my colleagues in DRC and in Nigeria, Abdul Kadir and Dr. Pomi, to share with you some examples of their national CLA mechanisms. And we hope you find this helpful. Really looking forward to your questions at the end. Thank you so much.
Super. Thanks a lot, Kees. So we love data. So it is fantastic to see that community-led monitoring, we can really see tangible facts and figures, right, on the impact of actions and community-led monitoring. So we're very happy as we love data. Maybe before giving the floor to a colleague from DRC, any question on what has been shared by Kees so far on community-led monitoring? Any question from all participants before we look at country examples? If you have any question, if you would like to raise your hands or so, otherwise we will directly move to the country experiences and we will take your questions afterwards. Okay. So as there is no question, I'm very happy to introduce Dr. Pomi. Dr. Pomi, if you would like to share, to switch on your video so that we can greet you. And we will invite Jonathan to move to the next slide. Super. Dr. Pomi, are you with us? We can't hear you. Can you please unmute yourself?
Hello.
Activate your microphone.
Bonjour à tous.
Hello, everyone.
Super. Thanks.
Okay.
Dr. Pomi works with Sandro and working with one of our principal recipients. She's a project manager. And I think your experience is very interesting. It is something new. It is about integrated community-led monitoring. So it is about community-led monitoring against HIV, tuberculosis, and malaria, as well as COVID-19. So to you, Dr. Pomi. Thank you.
Ok, merci. Bonjour à tous. Je suis un des
Okay, thank you, everyone. I'm one of the peer of Global Fund in DRC. So we put in place intervention of community-led monitoring in 3 provinces of DRC. And we are working with Foundation Form Plus and CNRC in Kinshasa and Central Congo. We started in the province of Maniema in 10 the region of the 18 that we have in the country. And then with COVID-19, we went to Kinshasa and Central Congo. And in the 2 provinces, we are in 7 health zone. And Central Congo, we are in 6. So we have 23 zones of health that we are supporting through the intervention of CLM. So the experience that we shared here is about the Maniema province. In Maniema, we work in 10 health zones, and we work with community organization. So we, from July to December 2021, we took time to train those organizations, reinforce their capacity, develop integrated modules, and we do the monitoring for the 3 diseases, malaria, TB, and HIV. And we also added COVID-19 and other aspects of health. So we harmonize the different modules, harmonize the tools, and we work for the monitoring, again, the 3 diseases. So it's the community itself that play a role in the monitoring of health issues at the health community health. So we found that there were problem of payment, like anything linked with tax and fight against malaria in the health center. We know all that Intran that Global Fund made available in our different countries, free entrance, but services are paid, so consultations are paid. And we also noticed that there were high payment on that, and communities themselves pay for their services. And we're also a problem of lack of stock for testing and medicaments. So even sometimes the entrants are available at the central level, and then we could still see some lack of entrant at the health centers level. So with CLM organization, like community-based organization, for do monthly monitoring at the health centers level, making sure that entrants are available, make sure that healthcare are provided correctly, make sure that there are entrants for the different diseases, and they also monitor the different site of care available at the center. Also, they do home visit to discuss about services that they receive from the different health centers and community centers. So this monitoring help have timely feedback from the community about what is being done at the health centers, and also at the district level, community level, and also at the community set level. As we are developing, we also have other sub-recipients who implement activities of Global Fund. So we have sub-beneficiaries who play an important role in terms of provision of entrant in health centers and also in care sites. And also we have sub-recipients who are actually act at the CLM level. So once the community organization find problem, they will share the feedback to the sub-recipient, who will play an important role in anything linked with provision, and then solution is found for the provision of entrant to the health center without issue, and anything that is about payment. So advocacy were actually organized so that the cost of consultation could be reduced in the health centers. So during 6 months, we compared the data from July to December 2021 with the data from July to December 2022, and we see that there is a big difference in terms of result. You can notice that the cost that was paid for access to treatment or testing for the fight against malaria was reduced from 4.1 to 0.7% for the testing, and from 2.7 to 0.7 for access to treatment. And those costs were suppressed for access to mosquito nets. And also we noticed the reduction of that cost from 1.4% to 1% for access to TB testing. We also saw that the lack of entrants were also reduced from 31% to 20% in health centers in the 10 zones of Maniema province. The main challenge that we had is the sharing of information. Up to now, we haven't done digitalization, and we are seeing how to actually use digital tools. So far, we are sharing information through papers, and those papers, you need to have time to analyze the different information, aggregate the different information, and also draw conclusion that can be shared with the different actors so that we can really have a solution to the different problems. And so this take time. So we really want to use digital tools for the CLM and in the 3 provinces so that we can quickly have timely data and help make a decision in a very short time. So this is an example that I would like to share with you about DRC, and I pass the floor back to Karin. Thanks, Dr. Prule, and congratulations for this initiative for integrated monitoring. Before giving the floor to Nigeria, do you have any question for DRC? So our participant, can you hear us? Do you have any question for DRC that Dr. Pony could answer? Okay. So, Dr. Prowe, if you could stay with us, that would be good. Oh, I see a question. There is a question.
Health facility governance committees often mandated to conduct, to conduct community engagement, be engaged in CLM processes.
Est-ce que
let me read the question again. Are there examples of adolescent girls and young women leadership in community-led monitoring and or examples of women's rights organization or youth-led organizations leading community-led monitoring? If yes, then what are the lessons and recommendations for ensuring adolescent girls and young women and youth lead community-led monitoring processes? Dr. Pomi, voulez que je vous traduise la question? Ou bien est-ce que notre traducteur
en fait, nous travaillons avec les organisations.
Oui, nous travaillons, so we work with community-based organizations, so youth association, women association, which are also intervening in this CLM. So they are really active and they work with our South recipient Fund Plus, and they share information and they help us correct the different weaknesses that we observe on the field. So young people and women also work with us in this CLM. And I can see that there was another question about digital tools. As I said, we have a big challenge, which is to computerize our data, CLM data. Up to now, we are still collecting information from papers. So now we are planning about using digital tool, and for sure, once we use digital tools, we would then be able to actually have a interaction with DHIS too.
Have health facility governance committee often mandated by to conduct community engagement, been engaged in community-led monitoring processes? Would you like to take this one, Keith?
Sure. And I just wanted to also point Ajita to a AGYW CLM mechanism that's currently being piloted or being rolled out in Lesotho. This is being done very closely, of course, with our PEPFAR Dreams colleagues, and it has a very particular approach to community-led monitoring where these programs are being implemented. So there is lots to learn as Lesotho is taking this on, but of course it looks different, right? Where adolescent and young women are congregating, for instance, through comprehensive sexuality education programs at the school versus youth-friendly facilities and also in community settings. The issues are very contextual. Of course, in Southern and East Africa, the risk to HIV infection is influenced by a number of different reasons than compared to West Africa, for example. But there is the Lucy-2 example that's worthwhile learning more about. It does integrate sexual reproductive health, gender-based violence, IPV, economic empowerment, and life skills in relation to HIV and tuberculosis. And like I said, this is a collaboration and partnership between PEPFAR and the Global Fund and the Ministry of Finance of Lesotho. In terms of the health facility governance committees, yes, this is typically a very strategic entry point for use of community-led monitoring data. I think prior to including this, let's say, in the terms of reference or the standing agenda of the facility committee, obviously very important for communities to prepare their CLM advocacy or CLM based advocacy asks to the facility themselves. It's also important to ensure that the health facility committee understands CLM not as a pointing finger mechanism, but actually as that co-problem solving solution. So we've had good examples in South Africa where the health facility committees have a civil society representative already on the committee, and the engagement then is to ensure that that representative has the skills and understand how to do advocacy using CLM data, but also to support perhaps a second representative coming from the affected community implementing the CLM mechanism to also share their reflections. So it's very much possible. It's actually something that's advised and recommended when it comes to that very local facility level advocacy and co-problem solving. This also creates a feedback loop where that same civil society representative can feed back to their constituency on what are the healthcare workers or the health facility management committee's reflections on some of the issues that they have also identified. And together they can go to subnational and state levels or national level stakeholders for improved accountability. And I'm saying many things, but at the end of the day, what this could lead to is, for instance, that there's not sufficient staff in the facility to serve the number of PLHIV accessing treatment. Plus, there are stockouts. Through engagement in the health facility committee, the civil society members have voiced these concerns to the facility management team and to the committee. And the committee has provided further intel on why that might be the case from the health facility perspective. Might be inadequate budgets for human resources for health, ensuring that there's sufficient healthcare workers. It might be a quantification issue at the national level to ensure that stock reaches the facility and it's the right quantities. So together, these can form the advocacy interventions going back up to different levels. I hope that's helpful.
Super, thanks a lot. Yes, it is. Now, this is a question to everyone. Do we have Ibrahim Abdulkadir with us? Or Ruth, are you the one who would present a newfound case in Nigeria? Okay, if I don't have an answer on this one, then I will give the floor to Deborah, and we would move to the next slide. Jonathan, please. Great, thank you. So, Deborah, it is super to have you. So Deborah is a star from the civil society and communities movement. She is from Nigeria, and she will share with a lot of passion the One Impact application against tuberculosis. So to you, Deborah, and feel free to switch on your camera. Thank you. Deborah, you have the floor. We can't hear you. You may need to unmute yourself, activate your microphone. Thomas, can you help us? Deborah?
Yes, give me a second. She's in the backstage room.
Super, thanks a lot.
Deborah, you should be able to talk now.
Deborah, can you hear us?
Yes, I can hear.
Okay,
Can you?
super. So if you want to switch on your camera, and you have the floor. To you. Deborah, you have disappeared.
Is it good now?
It's perfect. Please go ahead. We are delighted to have you with us. You have 5 minutes.
The slide that, yeah, this is not my slide actually.
Okay, Jonathan, we need to move to the next slide. Exactly. So to you, Deborah.
Thank you very much for having me. This is me from DHDC Nigeria. DHDC is a registered civil society organization that is deeply involved in changing poor health narratives across all primary healthcare areas through the provision of innovative health solutions. And with support from Stop TB Partnership Geneva through the CFCS project, we piloted the One Impact CLM in Alimosho local government area of Lagos State. The key issues that were identified that led to the integration and pilot of the One Impact in Lagos is the case of low childhood TB case notifications with specific emphasis on low TPT uptake, low level of awareness on TB, low level of awareness on the rights of people affected by TB. That is also supplemented with lack of access to justice, and also TB stigma and human rights violation. And so the One Impact was introduced. The One Impact is a free digital platform that provides the general public, but most especially people affected by TB, with information on tuberculosis, information on the rights of people affected by TB, access to information on all the healthcare facilities that provide TB services, but interestingly also a platform where people affected by TB, people on TB treatment can have direct interaction with TB survivors, and also a model, a part of the application, which gives them access to be able to report issues of human rights violation. And it's not just an application for people to use, but also it has the back end, which has different dashboards, which are the first responder dashboard and the accountability dashboard. The first responder dashboard gives access to TB survivors who are acting as first responders to be able to respond to the issues that are being raised by people on TB treatment, but also it helps the TB program to sit back in their office and be able to access information that would be able to provide them with direction to take policy decisions and take programmatic actions. So through the CLM, using the One Impact in Lagos, we were able to administer targeted surveys that were administered at the onboarding process to identify the potential gaps in the TB response, especially around childhood TB and TPT among priority groups. So through the One Impact, it allowed us to be able to collect information routinely around the barriers to quality TB services in Lagos State. And the results that we found from the pilot of this innovation in 10 primary healthcare facilities in Alimosho local government area of Lagos State are the fact that we were able to screen and initiate over 500 children on TB preventive therapy. And it's interesting to know that over 200 of them were initiated during a 1-week intervention. You can see what was done, through information that was collected from people on TB treatment who indicated through the One Impact that their close contacts who are children are not on TPT and TB program. We, in collaboration with DHDC, TB People Nigeria, we went to the grassroots and were able to carry out targeted intervention to be able to place these children on TB preventive therapy. Through the One Impact mass media and social media campaign, we're able to reach over 380,000 Nigerians with information on TB, TPT, and stigma. Also, over 600 people on TB treatment were sensitized on their rights, and 47 cases of human rights violation were reported through the One Impact, and all addressed through targeted interventions. We were able to reach over 5,000, I beg your pardon, children and their teachers with information on TB, TPT, childhood TB. They were all sensitized and provided with contextualized SBCC materials. So in conclusion, I would say that One Impact has strengthened the TB program oversight function through information that was collected through the One Impact, because they were able to identify the gaps that were serving as hindrance, to provision of quality TB services, as well as issues that were affecting the TB response. This project was carried out through, strategic partnerships with TB survivors of TB People Nigeria and DOT officers that were providing services at the primary healthcare level. Through this, we're able to also sensitize healthcare workers that would definitely, lead to the reduction of stigma in healthcare facilities. Thank you, Karine, and thanks everyone for having me.
Super. Thank you, Deborah, for the quality of work. It is amazing. Do you want to show us your app? Keep the camera on if you have your phone next to you and to show you the app. Because everybody got very excited when the One Impact application were shared. Everybody got very excited about it. So if you want to share your screen, your mobile phone, that would be super nice. Oh, you muted? Okay. We can't hear you, Deborah. Okay, now we can, yeah.
So this is my phone.
Yeah.
And the One Impact is available on Play Store and App Store. And I scrapped it out so that you can see. I don't know if you can see, but we were able to collect information at the onboarding process, where you'll be able to fill out information. And once information is, put in, and then you submit, you're able to access whatever service you would like to be provided with on the One Impact. So it's available for free of charge. I would encourage every single person on this call to go ahead and download the application free of charge. You don't have to pay for it. And I encourage other countries to also go ahead and integrate One Impact into their TB response, because it's a magic. It helps you real-time data that are provided from people that are affected by TB in the communities. So as you can see, this is the app. I already have it, on my phone just in a couple of minutes, seconds actually. I already have the app. You can see the 6 modules of the app that is being displayed. I have it here. If I want to access any healthcare facility, I'm able to, access it and all that. And interestingly, through the Get Connected, that's the one that excites me the most. You will see people that are on treatment directly chatting to say, hi, I'm about to take my medication. I don't have food. What do I do? There are people saying, I'm coughing out blood, but I just completed my treatment. What do I do? Have I been reinfected? And TB survivors are there sharing their own experience, because these are people that have lived the experience. So it is very important, because the TB program is also there at the back end, watching, looking at all of these issues where human rights violations are reported. The TB program is taking action rapidly. Okay. So this is a wonder, really. I encourage that all countries, pick this app up, and run with it. Thank you so much.
Super.
Karine.
Thank you very much. I said you were passionate about it. Thanks so much, Deborah. And I hear that your co-citizen from Nigeria and from Newfoundland is here with us, but maybe before giving him or her the floor, I think we have Patrick online. So Patrick is from Club des Amis d'Amiens in DRC. and is representing the survivors,
Allô, Karine?
tuberculosis survivors. So yes to you, Patrick. Patrick, si vous voulez ajouter quelques mots en 2 minutes.
Patrick, would you like to add 2 words in 2 minutes? All right, thank Karine for the floor. I just wanted to reinforce what Deborah has just said by saying that, yeah, for sure, one impact is a very important tool which really help us improve the quality of services, TB services, mainly for the availability and access, and even question in link with human rights, in link with discrimination, stigmatization of patient. But then what I would like to reinforce here is to say that it is an approach which should really be implemented at all levels in all the countries because it brings solutions in real time, and also it brings information in real time that patient or people affected shared in the treatment of TB. We started in DRC with 29 centers with 325 people affected as users. And in 2022, we recorded 1,011 people in 6 provinces which are users. So if you have to talk about the benefit of one impact, we just say that we notice an improvement of communication for addition to treatment for people under treatment, and also survival of TB. But also there have been, we've observed an improvement of the capacity of people under TB treatment, and improvement of capacity of health workers on human rights of people affected. In one impact, we have 6 modules, but it's a module which focus on the right of people affected by TB. And thirdly, I can affirm that there was an improvement for access to information on TB and testing services, because we should acknowledge that even members of communities sometimes they are very important, interested in this innovative approach, which help launch alerts on the problems, and those problems should find real-time solution. So we try to be in touch with professional coordinators, PLLT, which are also which receive all the problem shared by patient. And so at different levels, it's like a advocacy tool, which help us also reinforce the collaboration link between PLLT and the community. But also to end, one impact, we also observe the reinforcement of collaboration between family members, because there are some patients who are discriminated within their own families, but with one impact, they have access to more information. And from those information, those information are capitalized to raise barriers in link with discrimination, in link with stigmatization within families. Okay, thank you, Patrice. And to see the different implementations of one impact, the ideal for us is to go beyond what we are doing now. Thank you. Thanks, Patrick. Thanks, Deborah. Thanks, and Patrick, for the sharing of your experiences between in Nigeria and at DRC on one impact and TB. Dr. Ibrahima, are you with us?
If so, I will ask you to take the floor. And so Mr. Ibrahim Abdulkadir is from the network of people living with HIV in Nigeria, and he will share his experience on fighting HIV using community-led monitoring to fight HIV. So are you with us, doctor? Or do we have anybody from?
Yes.
Okay.
I'm not.
Super. So, Doctor, we're very happy to have you with us. If you have 5 minutes, if you don't mind sharing your experience on community-led monitoring to fight HIV in Nigeria with the achievements that you have made. Thank you to you, Doctor. And if you want to share your video. Thank you.
Yes. So please share the presentation. Okay.
I think can you see my screen? I think I have it.
Thank you.
On my screen. So
yes.
To you, Doctor.
Okay, thank you very much. My name is Abdul Qadir Ibrahim. I work for the Network of People Living with HIV and AIDS in Nigeria. And we are leading the implementation of the community-led monitoring on HIV in collaboration with the HIV civil society stakeholders in the country. So basically, this is a snapshot of our summary success. And as you can see from the highlight, basically what we do from the issues you see, we monitor the quality of services, looking at HIV service availability, stock out of medication and commodities, out of pocket expenditure, and also stigma and discrimination and issues related to gender and human rights. On the quality of care for HIV, TB services and the key population-related services to identify gaps and barriers to quality treatment of services using quantitative and qualitative approach for data collection used to gather evidence for advocacy and decisions making. And we have also work in different facilities across the country where these data are being analyzed and also are being disseminated based on the findings identified. So briefly,
the connection is not that good, I think.
Let me go into the I've achieved so far. Can you hear me? Hello?
Yes, we can hear you now. It broke a little bit before, so please go ahead.
Okay, maybe it could
Thank
be
you.
network. So you could see some of the successes. ARV stock out has dropped from 1.2% in September to November 2022 when we started the implementation of the Global Fund supported CLM implementation to 0% to February 2023 monitoring. This is a huge success due to the advocacy based on the stock out we have recorded. We also looked at viral load lab stock out, which has also dropped from 5.4% in 2022 to 0.3% in February last month. Then also dropped
difficult to hear. I can't hear you very well.
This is the current PLHIV. Maybe it could be network. Can you hear me now?
Colleagues, let us know if you can hear Dr. Abdul Qadir correctly. Or does it
Can you
break?
hear me?
Yes, we can now. I'm just asking.
Okay, so from the key population, it has dropped from 16.9% to 7.7%. So these are some of the successes recorded. Then the CLM implementation led to the development and launch of the first national CLM framework. This is one of the significant achievements we have recorded in Nigeria, where we have a guiding
Dr.
document.
Abdul Qadir. Dr. Abdul Qadir correctly? Yeah, I think it's the connection is not that good. I mean, I can't hear you.
Okay, so basically, these are some of our achievements, as you can see from the screen. If my internet is not stable, that's fine. But you can see the report. This is the summary of what we have achieved.
Thank you very much. Thank you very much, Dr. Abdulkader. And again, congratulations for all the achievements and all the work. So far, we have Nigeria and DRC who have kindly shared their experience on fighting HIV in Nigeria, fighting TB in DRC and Nigeria, and integrated the community-led monitoring, fighting the 3 pandemics plus COVID in DRC. So I understand there are also other stories that can be shared by our participants. So I saw, for example, someone from Latin America. So to you, colleagues, to all participants, if you have any experience that you would like to share, we would be very happy to hear from you. So just raise your hands and Thomas will give you the floor and activate your microphone. So I saw Sergio, I think, from Latin America, sharing example. I see also CLAW. So anyone who would like to share his or her country experience? And as I wait to get some volunteers, I have a question to you, which is which kind of support would your country need from the Global Fund or others in order to implement community-led monitoring? So that's my question to you. And I see that we have one person who raised their hand. So Sergio, yes, please go ahead. If you would like to introduce yourself.
Gracias. ¿Me escuchan?
Yes, thank you. Can you hear me? Sí, I will speak Spanish. So I was telling you that from REDCA, the Central American Network of People Living with HIV, since 2021, we have defined a model led by the community in 4 countries of the region, and these are Guatemala, El Salvador, Honduras, and Panama. So we monitor. We have several elements of what we have discussed based on the experiences also that have been shared. And this model is focused on monitoring quality of the services on the HIV services on those centers that receive direct support from PEPFAR. So as of now, we have information of 38 services of 4 different countries, and we are also collecting this process. This is a cyclic process where based on the information that we gather, we can just table this information and we gather the presentations. And then after that, we develop different dialogue centers with this multi-sectoral participation in those 4 countries. And based on those discussions, we have these improvement plans for those services that need interventions according to those qualifications that are received for each of the services. And this is important because this community-led monitoring based on REDCA is not to monitor the country itself and just to say the country is like this. No, the idea is to establish specific indicators so we can work together and directly in each one of those services where we receive this attention, but also to prevent HIV. So in this case, we expand to those services given to key population in all the services. So we have this model. I just added a link, the chat box of this monitoring, and there's a video that we have. We are also launching the second stage, and we're coordinating with the national programs of each of these 4 countries, Guatemala, El Salvador, Honduras, and Panama. So we hopefully that by the end of this year, we can have more information of these new sites that are being monitored, besides the monitoring that we have done to those the improvement plans that had been implemented in these discussion sessions.
Excellent, thank you very much. Muchas gracias por eso, Sergio. Do we have other colleagues online who would like to share experiences? And then I see that we have also a question in the chat. Kees, if you can see the question, if you would like to answer, you have the floor.
Thank you so much, Corinne. So Sue has already provided some answers. I didn't know of JotForm, so I knew of Kobo Toolbox, so we are learning together today as a very, very, very important point highlighted by Adetto in terms of access to smartphones and whether alternatives exist. So there's the Kobo Toolbox, and then there's JotForm. So I urge you to follow some of those links to learn more about those different options. Abdul Kadir has already answered the question regarding the role of the government in terms of the CLM framework, and I agree with what he was saying in terms of co-chairing the steering committee, but I think there is also a level of accountability and ownership that's expected from government for the CLM mechanism to function. And you can imagine in several contexts for government to play a role in ensuring safety and security of monitors themselves, particularly when it comes to key population members or civil society members that are part of or communities of key populations. I don't think there are any other pertinent questions. Bonita, thank you so much for sharing the example from Tanzania. So if you really look at the principles of community-led monitoring, this is a prime example of community-based monitoring, if you will. So it's not necessarily led by civil society and or communities themselves. This is an extension of what a community health co-worker would do and collect data on at the level of community, like you are saying, making sure that all the HIV services have been received by clients accessing. A community-led monitoring approach to that would be for networks or groups of people living with HIV or not living with HIV, accessing that facility to also assess how people's experiences has been. So this would be quantitatively measuring whether you've received the 4 services you are meant to receive as part of the essential package or the minimum package of services that's available at that facility. And a community-led monitoring could complement that information to say, okay, 90% of people do receive 4 out of 4 services as per the guideline or as per the standard operating procedures. Or it could also show that there are some people who's only receiving 2 out of the 4 services, and these are the experiences about why. That's the improvement component that you can then build onto, and engagement with community health workers and healthcare workers within the facility, and that feedback loop between them and the clients or the service users could be a pretty impactful model if you already have some sort of a compliance monitoring built into it through the community health workers. I see comments from Mike, also from Nepwan, and others have also shared some additional information. So I'll stop there, Corinne. I don't think if there's anything particular, please raise your hand. We can have a discussion. More than happy to do so. Back to you, Corinne.
Thanks a lot, Kees. Thanks a lot. Any burning question or any experience that colleagues want to share? If so, please raise your hands. Otherwise, we will wrap up. So, the series.
There's one hand, Corinne.
Yes, please. Okay, thank you.
Yeah.
So, Deborah, you have the floor.
Yeah, I saw a question in the chat box and I just provided the response to it. I just wanted to echo that. Someone was making reference to TB being a disease of poverty and that are there initiatives for people who are not able to access smartphones? So I just put in there that the One Impact is also built to support those who can have access to mobile phones and those who can't have access. And that's why it also comprises of the assisted model, which is built to support people on treatment who do not have access to mobile phones, and also to use this opportunity to inform everyone that the One Impact is now being integrated into the national hotline in Nigeria, which is the 3340, for members of the public to also be able to access One Impact without internet. So yeah.
Super, thank you very much, Deborah. So listen, that was the last of our series on community health, where we tried to unpack the strategy in community health. We hope this has been useful. I have included in the chat two things at the beginning. I have shared with you the web page of the Global Fund, where all our presentations are posted in 6 languages. The objective of this series is also to cross-fertilize between regions. So feel free to share that with all your partners, colleagues, maybe government or civil society, communities, key populations, etc. Do share with us your experiences, and we will be very happy to circulate those experiences, because all the experiences are with you, right? And that's what we really want to share. And the last thing, I have included also the link to the Menti. So our 2 last questions to you is basically, what is your takeaway from this session? What will you remember from this session, and what will you do with this information? So for us, it is very important to know, so that we can continue the work and best support you. Again, we have 1 last minute. So if you want to tell us what else we need, which kind of support you need to further strengthen community health in your countries, please feel free to do so. And I'm also aware of time. So any last minute question or comment before we wish you all a lovely day and a lovely evening?
Thank you so much, everybody. And remember, the community-led monitoring team at the Global Fund Secretariat is available. I think at the end of the slides, my email address is there, and so is Susan Perez's. So please reach out if you have questions, if you need support, if we can link you up to some resources or some partners doing similar works, then you are very, very happy to facilitate that for you.
Super. Thank you very much, Keith. Thank you to Susan. Thank you to Gemma, Jonathan, Thomas, all our translators who made it possible to cross-fertilize between regions, the regional platforms also, of course, and Gemma. So listen, we're here to support you. You have our email address, so keep it up, and again, send us all your experiences. All the very best. Good evening, good afternoon, and a lovely day to all. Cheers.
Thanks, everyone. Goodbye.
Bye-bye.
Thanks, Karen. Thanks, everyone. Bye.
Thank you, Deborah. Thank you, Dr. Parmi. Thank you, Patrick. Thank you, Abdul Kadir.